en inglés con muy mal inglés, pero para que ellos me entiendan un poco la introducción. It's our honor to present Dr. Nasr and Dr. Nelson Leung. They are very recognized internationally speakers and investigators. They both are in Mayo Clinic College of Medicine, and we're going to be able to we hope that we learn a lot with them. And now, a little bit in Spanish. Nosotros lo que haremos ahora es, ellos presentarán sus comunicaciones y luego, en el momento de las preguntas, les rogamos que sean preguntas muy directas, muy cortas, para que haya mucha gente que pueda preguntar y puedan nutrirse de estos dos excelentes exponentes. Gracias.
I'm so pleased to introduce our next speaker, Professor Dr. Nasr. Dr. Nasr is a top expert in kidney pathology with over 200 published papers. His research has fundamentally changed how we understand diseases such as MGRS and for using new technologies such as mass spectrometry. We are very happy to have him with us. And please, Dr. Nasr.
Thank you for the introduction. I would like to thank Dr. Kanata and Fernandez for the kind invitation to participate in this conference, and I look forward to spend a few extra days in Madrid. So, in the first half of the talk, I will discuss the pathology and classification of amyloidosis and the typing of amyloidosis, and Dr. Leung will take over with the hematologic aspects and treatment. Okay, let's see how we're going to advance the slides. Okay, so as you know, renal amyloidosis is among glomerulopathies with organized deposits, and these are rare, collectively account for about 4% of native kidney biopsies, and amyloidosis is the most common of which. As you know, amyloidosis is a group of diseases that result from tissue deposition of misfolded proteins with extensive data-pleated sheet formation. Histologically, and regardless of the type, amyloid deposits share two characteristics. They stain positive with a concurrent dye with anomalous colors under polarized light, and on EM they show randomly oriented straight fibrils. It's important to distinguish localized forms of amyloidosis, which are often innocent, from the systemic forms, which are almost always a threat to the patient. There is significant overlap in the systemic manifestations of amyloidosis, and the manifestations in general are determined by the precursor protein and the affected organs, but again, there is significant overlap, and therefore, tissue typing is very important. There are currently 42 non-human amyloidosis types, 14 of which are systemic, and the remainder are localized. And you can group amyloidosis into three types: mutant, acquired, and iatrogenic. Sometimes, some types can be acquired or mutant. On the right is amyloid is the kidney is a prime site for amyloid deposition, and on the right is a list of amyloidoses that may have clinically significant kidney involvement. The three most common types are AL, AA, and ALAC2. ALAC2 is leukocyte chemotactic factor 2 amyloidosis. Hereditary amyloidosis, most of them involve the kidney, the most common of which is fibrinogen alpha amyloidosis, which is more common in Europe than the United States. These hereditary forms are rare, collectively account for about 5% of renal amyloidosis. AL is by far the most common type in the developed countries, 80 to 85% of cases. The incidence of AA is declining, but it remains one of the most common types in the developing countries, for example, in this series from Egypt. ALAC2 is distinct than the other variants in that has a propensity to affect certain ethnic groups, particularly Mexicans, Arabs, Punjabis, and First Nation people of British Columbia. As you can see here in the United States. So diagnosis of amyloidosis is 3 steps. First, and the crucial step, is clinical suspicion and biopsying the appropriate organ. This is followed by establishing the diagnosis by Concorde or by EM, and then by typing of renal amyloidosis. And in the case of renal amyloidosis, the first step is done by the nephrologist or hematologist, whereas step 2 and 3 are the pathologist's job. As you know, we're all familiar with the morphology of amyloid, acellular eosinophilic material, which stains PS negative and silver negative. The current gold standard for amyloid detection is staining positive with a Concorde dye with anomalous colors under polarized light, although rarely you can have Concorde negative amyloid. And as pathologists know, you have to have thick sections, bright light source, dim the room light, and it's preferable to examine the slides under fluorescence light. If you do that, and you use the FITSI filter, which is used in routine immunofluorescence, amyloid will look dark orange. And by doing this, you can pick up small amount of amyloid that can be missed by bright light. Of course, there are other stains for amyloid, but these are not as specific. The most commonly used is the thioflavin. Nevertheless, you need to confirm with the Concorde. And as I mentioned, all types of amyloidosis will show this randomly oriented straight fibrils on transmission electron microscopy. So certain types of amyloidosis have different distribution in the kidney, but there is significant overlap. For example, immunoglobulin-related amyloidosis most of the time involve glomeruli and vessels, and the tubulointerstitium is involved in about 2/3 of cases. One characteristic feature of immunoglobulin-related amyloidosis is amyloid spicules. They look like eyelashes on the silver stain, and this results from parallel alignment of amyloid fibrils perpendicular to the glomerular basal membranes. This is more common in AL than AA and is very rare in the other forms. So there will be 3 twists. I find them interesting twists in amyloids that I will mention. The first one is intracellular amyloid. If you think of amyloid, you think of extracellular deposition of amyloid fibrils, misfolded proteins. But in fact, rarely you can have intracellular distribution. And this is a multi-center study of 21 patients with intratubular cytoplasmic amyloidosis. Most of these patients have a concomitant amyloidogenic myeloma cast nephropathy, but not all. And therefore, they present with acute kidney injury, and most of the time they have high tumor burden. They have symptomatic myeloma. But for a pathologist, you can suspect this with the silver stain, because you can see these star-like inclusions or spicules within the tubular cells. And then you can do Concorde and you confirm it. And of course, by EM, typical fibrils. AA amyloidosis, most of the time, also involve glomeruli, vessels, and tubulointerstitium. When it involves the medulla, it tends to show this striking streaming pattern owing to extensive involvement of the basal membranes of peritubular capillaries and collecting ducts. So there's something distinctive about this. ALAC2 always involves the interstitium, usually diffuse. Glomerular involvement is variable. Sometimes you have extensive glomerular involvement. Other times, the glomeruli are completely spared, and these patients don't have any proteinuria. And it tends, I'll go back, sorry. Okay, I think I can go back here. Okay, so it tends to involve the cortical interstitium. The medulla is usually spared or even only minimally involved. In the liver, also, it has characteristic appearance. As opposed to the perisinusoidal involvement in AL, it shows this globular, periportal, or perivenular distribution, very characteristic. So since the initial studies on ALAC2 were mostly in the kidney and the liver, it wasn't clear if this is systemic form or not. But based on this study that was done on Hispanic dissidents in New Mexico, where they found amyloid in 3% of cases, so this is not uncommon, and nearly all cases have involvement of the kidney, liver, heart, adrenal, and spleen, so it's clearly systemic. There was no involvement of myocardium or brain, and the absence of myocardial involvement explains why the patients with ALAC2 have excellent overall survival. AFib, fibrinogen alpha amyloidosis, also has a characteristic appearance. Most cases show this massive obliterative glomerular involvement without much of extra glomerular involvement. And ApoA1, ApoA4, these tend to involve the medulla, and therefore they can be missed if the medulla is not sampled. So that's something about these two. And ApoC4, this is the newest form of amyloidosis. Most cases show this nodular appearance that can look like diabetic glomerulosclerosis, but of course these are PS negative. So to summarize, if you see amyloid spicules, think of AL, less likely AA. Extensive cortical involvement, think of ALAC2. Glomerular solidification, think of AFib. Medullary involvement, ApoA1 or ApoA4, and then nodular appearance, think of AA amyloidosis or ApoC2. Of course, these should not substitute for amyloid typing, but it's important because we're dealing with small biopsies and you have a case that has a massive glomerular involvement, suspicious of AFib or medullary involvement, then don't waste any tissue doing CLEC2 immune stain or AA stain. Proceed straight with mass spectrometry. Crescents, you can see crescents in amyloidosis rarely, and both AL and AA, they tend to involve small minority of glomeruli, but you can have diffuse crescents, and patients present with RBGN, some of them have positive ANCA, not all. So AL amyloidosis can be concomitant with other monoclonal gammopathy lesions. Most commonly, light chain deposition disease. This is in about 4% of cases. Less commonly with CAS nephropathy or light chain proximal tubulopathy. And this is a series that we did, the multi-center study, 37 patients with LCDD plus AL. Notably, amyloid involved only the vessels in 25% of cases. And therefore, if you have a case of LCDD, it's important to do concurrent just to make sure you don't miss concomitant AL, because it can involve only the vessels. Conversely, you always have to type renal amyloidosis, even if there's concomitant light chain deposition disease or light chain CAS nephropathy, and you shouldn't assume that it's an AL. For example, this is a case of a patient with myeloma with acute kidney injury, and the biopsy shows light chain CAS nephropathy. You see abundant PS negative casts, kappa restriction, but there was amyloid extensively involving the interstitium, and this turned out to be ALAC2 amyloidosis, both by immunostain and mass spec. What's the differential diagnosis? Is conchophilic fibrillary glomerulonephritis. About 4% of cases of fibrillary GN have concurrent positive, and they can be confused with amyloid. And you can distinguish them by doing DNA JB9, which should be positive only in fibrillary GN, or by mass spec. So amyloid typing, this is important for classification of amyloidosis and for treatment and prognosis. And this can be done by multiple methods. I will only address the top 3 methods here. So since most cases in the kidney are AL, and since we have immunofluorescence in the kidney, we can type renal amyloidosis in 80% of the cases by immunofluorescence alone. But there are some limitations. As you know, frozen tissue may not be available. It cannot determine the type if it's not immunoglobulin-related. It fails to diagnose about 10% of cases of immunoglobulin-related amyloidosis. And more importantly, in about a quarter of cases, you can have false positive staining for intact immunoglobulins in non-immunoglobulin-related amyloidosis, and this is particularly true for AA. So positive immunoglobulin light chain staining for one light chain without intact immunoglobulin staining in the context of concurrent positivity is sufficient to diagnose AL. So you can diagnose AL by immunofluorescence. On the other hand, the diagnosis of AH and AHL is best established by mass spectrometry, and that's because of the occasional false positive staining of intact immunoglobulins. So if you have a case like this where the amyloid in the vessels and the glomeruli staining only for lambda with no staining for IgG or IgA, this is AL, no further typing is needed. If you have a case like this where bright staining for IgG, this is suggestive of heavy chain amyloidosis, but you still need to confirm it by mass spec, again, because of the issue of non-specific entrapment. And this is a case, 63-year-old female. She had no M spike. Amyloid deposits show strong staining for SAA, but also on IF staining for IgG. So is this AH or AA amyloidosis? And mass spec was clearly AA amyloidosis. Dr. Leung and Suarez led this Mayo Clinic study comparing IF versus gold standard mass spec to distinguish immunoglobulin-related amyloidosis versus non-immunoglobulin-related amyloidosis. And as you can see, 16 out of 104 MS confirmed cases of immunoglobulin-related amyloidosis had negative IF. So sensitivity of IF for diagnosing immunoglobulin-related amyloidosis was 85%. Conversely, 5 out of 66 cases of MS confirmed cases of non-immunoglobulin-related amyloidosis had positive IF. They were all AA amyloidosis. So specificity was 92%. So bottom line is relying on IF alone to diagnose immunoglobulin-related amyloidosis may lead to misdiagnosis. With regard to immunohistochemical stains, the most common one, as you know, is the SAA immunostain. This has high sensitivity, but this can also be false positive. In fact, in our lab, where we have in-house mass spec, we discontinued this immunostain because of this specificity issue. The other immunostain that is now widely used is the LEC2 immunostain. This one has also high sensitivity, but again, this can be false positive. So we have to be careful, and you can minimize this false positivity by avoid it by minimizing the antigen retrieval step. That brings us to mass spec, which is currently the gold standard for classification of amyloidosis. And this is typically done by the bottom-up or shotgun proteomic approach. And we have been using this technique since 2008, and we already did more than 50,000 clinical samples. So we have a good experience with this. So and this, how this works, we stain, we cut thick sections, 10 microns, stain them with concurrent, visualize them under fluorescence light, microdissect the conchophilic deposits. These undergo heat-mediated antigen retrieval, followed by trypsin digestion, then analysis by liquid chromatography and tandem mass spectrometry. And with the help of complex bioinformatics, we can determine the identity of the precursor protein. And these are displayed in a program called Scaffold. So when I am on mass spec rotation, I get 30 to 35 of these clinical cases. And the first thing when I look at this is I ask myself, let me show you here. And then, so we list the proteins on the left. On top is we list the amyloid-associated proteins, and then underneath them the non-amyloid, most abundant non-amyloidogenic proteins. And then this is the molecular weight, and these two columns are two separate microdissection specimens of the patient, and the numbers represent the total spectra that match to the identified proteins. And this is the confidence level in protein identification, and we like to stay in the green. So yeah, so when I am in mass spec, the first thing I ask myself, I look at this scaffold, is this amyloid? For that, I need to see the amyloid-associated proteins, which are the SAP, ApoA, ApoE, and ApoA4. If I see them, I know this is amyloid. And then next step is what type of amyloid, and then I look for the non-amyloid-associated proteins. In this case, you have a lambda constant region and lambda V6, which is known to have a tropism to kidney involvement. So this is an AL lambda. This is another case. Again, I see the APO4, APOE, and SEB. So this is amyloid. And then I see large spectra for transthyretin. And not only this, but I can see the mutant transthyretin. So this is the ATTR-V122I. And that's how it works. So this is has more advantages than immunohistochemistry because it doesn't require pre-knowledge of the suspected type, and it can detect the mutations in hereditary amyloidosis and identify new types. In fact, the insulin, ApoC2, ApoC3, all these were diagnosed by mass spec. It has some limitations that I listed here. And, but again, in the kidney is different. Since IF alone can diagnose 80% of cases, you only need to do mass spec in about 15% of cases, so not every case. Although our hematologists, they're very, argue strongly on doing mass spec in every case. So if, for a renal pathologist in the audience, if you have a patient that had negative monoclonal protein studies, and then you can do mass spec, then this is something you can do. But for us, we don't do mass spec on an outside cases if it's clear cut by immunofluorescence. AL, not heavy chain. Heavy chain, definitely we need to do mass spec. Okay, so this is the other second twist that I will mention. And based on our large mass spec experience, we learned that about 0.2% of patients with amyloidosis have two types. And these two types, they can involve same anatomic compartment in the same sample, different anatomic compartment in a same sample, or different organs. And the most common combinations are AL plus ATTR, which makes sense because these are by far the most common systemic amyloidosis. The most common organ is the heart, and the most common situation is you have a patient with M spike and heart failure. They do cardiac biopsy and it shows both. Kidney is not that often involved with this. Of these 9 cases that kidney was part of the organs, 5 had amyloid in the kidney different than the amyloid in other organ. So this is something to keep in mind. This is the last, third twist that I will mention is that drug nephrotoxicity has now extended to renal amyloidosis. So there are currently 4 known iatrogenic forms of amyloidosis, and these are listed here: insulin, enfortumab, GLP-1 analogs, and the interleukin-1 receptor antagonist anakinra. These appear as subcutaneous nodules, and they can be diagnosed by mass spec. Of these, only anakinra has been shown to can have a systemic involvement. And we have recently reported 2 cases of anakinra-associated systemic amyloidosis with kidney involvement. Both patients had neonatal onset multi-system inflammatory disorder and have been on anakinra for many years, high doses. And the kidney involvement is characterized by glomerular involvement, but more interestingly, this peritubular capillary involvement. Take-home points from this lecture is 95% of cases of renal amyloidosis are 3 types: AL, AA, or ALAC2. Some forms have distinct morphology. The pathologist's role is not only to diagnose amyloid, that's not enough, you need to type it. And then mass spectrometry is a powerful tool for typing of amyloidosis and discovery of new types and variants. And I will end up with this question. I have this portrait in my office. What type of amyloidosis do you think it represents? So who goes with A? B? Okay. C? Okay. D? Wow, I'm very impressed. Yeah. So yeah, this is what you see here, this massive glomerular involvement without much in the vessels or interstitium. So this is typical of AFib, fibrinogen alpha amyloidosis. Thank you.
Thank you, Dr. Nasr, for your excellent talk. We will have the questions at the end of the session. Thank you.
I am really, estoy encantada de presentarle al doctor Nelson Leung, que es professor in the College of Medicine of Mayo Clinic, and is consultant of nephrology and hematology in Mayo Clinic. Is an international recognized because the contribution in the study and research about amyloidosis and gammopathy, monoclonal gammopathy, especially with renal involvement. Bienvenido a España.
Thank you, Monserrat, for that introduction, and thank you very much for inviting me for this talk. And I think after the last talk, you know why Dr. Nasr is more famous than me. He's given a master talk on how to diagnose amyloidosis. After he's done all the hard work, I think we're going to have a little bit more fun with this. So you saw this figure earlier. There are 42 types of amyloid as of 2024, and 14 of these involve the kidneys. Now, we don't have time to go through all of them, and this morning, fibrinogen was discussed thoroughly, so we don't have to talk about that. Dr. Nasr talked about a lot of these. So we're going to focus on the four most common types of amyloid that is systemic. So first is AL amyloidosis. Now, let's take a poll. How many of you have seen a patient with AL amyloidosis? Oh, quite a few. How many of you think that you'll never see a case of patient with AL amyloidosis? Very good. How many? Because if you look at the incidence of AL amyloidosis actually has a higher incidence than minimal change disease in adults. Not in kids, but in adults, it's actually higher. It has about the same incidence as membranous nephropathy. And of course, IgA nephropathy and ANCA vasculitis has more. But oftentimes I'll hear physicians says, I'll never see a case of AL amyloidosis. Well, if that's your thinking, then you wouldn't think that you would see a case of membranous either. And none of us would think that we would never see a case of membranous in our career. Why is this important? Because the prognosis of the patient depends on when you diagnose the amyloidosis. As you can see, patients with stage 1 amyloidosis do a lot better than stage 2, stage 3A, and stage 3B. In fact, patients that are diagnosed at stage 1 amyloidosis have the same prognosis as those who have a complete response or a very good partial response after treatment. So diagnosing these patients early is extremely important, and you will save their lives. Now, how do we diagnose AL amyloidosis early? So these patients come to us because they have proteinuria and mild renal insufficiency. But the clues that make you think that there may be something more than just diabetic nephropathy or nephrosclerosis is the other systemic symptoms. Now, AL amyloidosis is a systemic disease. It can involve every single organ that you can think of. You might say that it does not involve the brain, but actually there are patients that have amyloidomas in the brain, so it can even involve the brain. Now, not every patient will come with a thickened tongue. Not every patient will come with two ecchymosis with their eyes, but patients will come with cardiac symptoms, with heart failure, peripheral neuropathy, and a big one for me is orthostasis. Your normal nephrotic patients will be hypertensive, but these patients will come with either normal blood pressure, or a big clue is that they had hypertension before, and now they're no longer tolerating their antihypertensive. They have been lowering their antihypertensive because of hypotension. GI and carpal tunnel symptoms are also clues. So recognizing these in your patients will help you make a diagnosis earlier. Now, we have pretty good treatment now for AL amyloidosis. The Andromeda study used daratumumab, which is an anti-CD38 antibody, and added it to bortezomib, cyclophosphamide, dexamethasone. And as you can see, the addition of daratumumab improved the very good partial response rate by 29%, and this correspondingly also increased the renal response rate by 29%. And as a result of the addition of daratumumab, you see that there's a significant improvement in the combined organ deterioration and overall survival of these patients. And now we have a method of measuring renal response in these patients. Renal progression is defined by a greater than 25% decrease in the eGFR. Renal response is defined by greater than 30% decrease in proteinuria without progression, so without the drop in GFR. However, as you can see, even patients that have renal response will progress to end-stage kidney disease. And that's because we know now that the 30% renal response is actually not enough. This is a new graded renal response criteria created by Dr. Muhtar when he was at the Mayo Clinic. And as you can see, patients who had a 30 to 60% reduction in proteinuria, which is represented by this line here, the orange line, they actually didn't do very well. In fact, these are the patients that progressed to end-stage renal disease. And it is really the patients that had a very good partial response, which is greater than 60%, and the patients that had a complete response, where the proteinuria is less than 200 milligrams, they're the ones who did really well and preserved their kidney function. Now, what happens if they lose their kidney function? Well, a lot of people say that you cannot do a kidney transplant on these patients. And we have shown for many years that actually you can. And in fact, this is a multi-center, multinational study by the International Kidney and Monoclonal Gammopathy Research Group. And what we showed was that the median graft survival and median overall survival were over 8 years in these patients, proving that they're actually doing quite well. And in this UNOS study from the United States, you see that the graft survival and kidney survival is actually comparable to those with diabetes. The only patients that did better were the diabetic patients that had a living donor. But diabetic patients with a deceased donor had a similar graft outcome and a similar overall survival than AL amyloidosis. So if you're willing to transplant a diabetic patient, you should be able to transplant an AL amyloidosis patient. Now, I just want a quick word on antifibril therapy. So previously, all of the therapies in AL amyloidosis have been targeting the clone, the plasma cell that is making the light chain that creates the amyloidosis. However, over the years, people have been trying to develop therapies that actually target the fibrils and try to either stop them from making amyloid or target the amyloid and take out the fibrils. Now, unfortunately, the first 3 trials failed. In fact, bertibimab actually failed 3 times. There were 1 phase 2 and 2 phase 3 studies that failed. So that drug is dead. But there are a couple of extra, the KALE 101 study just finished last year, Now, it failed too, but it didn't fail completely. And it turns out that patients with kappa light chain amyloid did better than the patients with lambda light chain. And it turns out that the antibody was actually created for kappa light chain. So we used to think that these antibodies are pan-amyloid, and it's not. And the KL-101 really showed that the type of amyloid that created the antibody makes a difference. AT01 and AT02 are not antibodies. They are small peptide molecules that are created to bind the backbone of amyloid. And they may be the only molecules that are pan-amyloid, but the studies are still ongoing, so we don't know the results of that. This is a chart of the different types of amyloid seen at the Mayo Clinic. Dr. Robert Kyle used to update this chart every year. This was back in 2006, and as you can see, at that time, we've seen 4,600 cases of amyloid. As Dr. Nasr said, the second most common type of amyloid is the AA amyloid, or the secondary amyloid. Now, why do we call it secondary amyloid? It's secondary because it's almost always secondary to something else. So the most common causes are infection, autoimmune diseases, and hereditary inflammatory syndromes. And what these conditions, and there are some miscellaneous conditions such as skin popping and Castleman disease, which you heard earlier, but these inflammatory syndromes cause a rise in the SAA via cytokines such as IL-1, IL-6, and TNF-alpha. And they cause an elevation in SAA1, which is then deposited in organs. Now, unlike AA amyloidosis, where heart and kidneys are equally involved, as you can see, this is a spleen, by the way. And actually, embarrassingly, I was an author in this paper, and I couldn't remember what this was. I thought this was a kidney, but these are the kidneys. This is a spleen. The kidneys are involved 97% of the time by SAP scans, the liver 23%, and the heart only 2%. So big difference between AA and AL amyloidosis. One interesting thing is that the incidence of AA amyloidosis in the US and in Europe are quite different. In the US, as you can see, the ratio of AA amyloidosis to AL is 17:1, whereas in Europe, AA amyloidosis is only 2:1, or the AL amyloidosis is only 2:1 higher than AA amyloidosis. And that's probably because of familial Mediterranean fever, which is much higher in the Europe than in the US. There are 3 other periodic fever syndrome, the TNF-alpha receptor associated periodic fever syndrome called TRAPS, Muckle-Wells syndrome, and hyper-IgD syndrome. So management of AA amyloidosis really comes down to managing the cause of the inflammation. For infection, the most common is TB, osteomyelitis, and bronchiectasis. Controlling the infection is important, although sometimes you really can't control these infections. Autoimmune diseases, we try to control the inflammation with the disease-specific biologics such as TNF-alpha blockers or IL-6. And then in hereditary inflammatory syndrome, we also use biologics. And this is a study out of the UK looking at the SAA levels of patients with AA amyloidosis. And as you can see, those who have a high SAA levels are those who are more likely to progress, whereas patients who have disease regressions are the ones with a low SAA level, actually below 5. Now, unfortunately, well, SAA is available in Europe, but it is not available in the US, so we cannot use this assay to track our patients' response. I'm just going to go over a few studies looking at the use of biologic. This is the Regate registry using tocilizumab in patients with AA amyloidosis. This small study consisted of 12 patients. 8 of them have rheumatoid arthritis, 1 had familial Mediterranean fever and TB, and 3 had unknown causes of AA amyloidosis. As you can see, many of these patients have received prior therapies. The thing is that tocilizumab doesn't work in everyone, but in the patients that do, they have rapid improvement in proteinuria or renal function. However, about a quarter of these patients actually progress on tocilizumab, so no biologic works for everyone. Specifically, in the rheumatoid arthritis patients, the arthritis actually improved in 6 out of 8 patients, but actually 4 patients discontinued because of ineffectiveness to control the amyloidosis. So that's one thing that in rheumatoid arthritis patients, just because their arthritis is better, it doesn't mean that the inflammation is better, and you still have to measure the SAA level in these patients. This is just a chart of all the familial periodic fever syndromes. These are the genes the mutations that cause the syndrome. And as you can see, as you all know, colchicine is effective in FMF, but only early, because once they develop amyloid, colchicine is really not that effective anymore. And you have to switch to one of the biologics, such as tocilizumab or anakinra. One thing about TRAPS syndrome, which is the TNF-alpha receptor syndrome, not all TNF-alpha blockers are the same. In fact, infliximab, which is one of the TNF-alpha blockers, can cause a periodic reaction where they cause a flare in the TRAPS syndromes, and we don't really understand why that is. This is a study of TRAPS syndromes using different biologics, as you can see here. And you can see that actually the most effective is etanercept and canakinumab, which is a long-acting IL-1 beta blocker. When these patients respond, you see that proteinuria drops within the first month, and SAA level drops along with it. So again, using SAA as a biomarker, a drop in the SAA really result in an improvement in the proteinuria. This is looking at anakinra in patients with AA amyloidosis secondary to familial Mediterranean fever. As I told you, once they develop AA amyloidosis, you probably need a biologic to control these patients. 36 of them received anakinra and 4 had canakinumab. They had really good results with this. Almost 80% had either improved or stable kidney function. Only 20% of them deteriorated. And in these patients that deteriorated, I would probably use an IL-6 blocker. Now, I said almost all patients with AA amyloidosis are secondary, but we have found some primary. This is a study of European families that have primary AA amyloidosis, and these hereditary AA amyloidosis patients is the result of a mutation in the promoter of SAA1. And more recently, we actually found the first family with a mutant SAA1 peptide that form AA amyloidosis, and this paper was just accepted by the Kidney International. Moving forward, ATTR, which is another very common type of amyloidosis. Now, ATTR is probably more common than ALEC2 and AA because most of the ATTR patients don't have kidney involvement, or we don't think that they have kidney involvement, and they have heart involvement. If you count all the wild-type ATTR patients, they're probably more common. So again, the ATTR has a hereditary type, which many of you are familiar with, especially those who have patients from Portugal. But we also have a wild type, which are mostly in older males. However, ATTR can involve multiple organs, the most common being the peripheral nerve, heart, autonomic system, eyes, and soft tissue. These are the previous treatments that are for ATTR amyloidosis. People used to do liver transplant because the TTR peptide is made in the liver. However, we don't do that as much anymore because, one, not all patients improve. Two, there's significant comorbidity with the liver transplant. And three, we have better drugs now. There are stabilizers, diflunisal and tafamidis for cardiac ATTR, and then the RNA silencers, which has ASO and RNAi that are used. And then more recently, CRISPR has also been used for hereditary ATTR. Just one note, the kidney involvement in ATTR was not well recognized. In fact, the International Society of Amyloidosis did not recognize kidney involvement in ATTR until 2022. Prior to that, it was thought to not involve the kidney. But this study from Portugal really showed that kidney involvement is common in ATTR. In this study, they looked at 32 patients that had symptomatic ATTR. 13 of them had microalbuminuria, and 9 had overt nephropathy, and kidney failure developed in 4 patients. Even in the patients that have no proteinuria, eventually 11 of them develop microalbuminuria after the initial diagnosis, and once they develop microalbuminuria, nephropathy and renal failure follows. In the patients asymptomatic, they can still have albuminuria, and again, the pattern follows, overt nephropathy and then kidney failure. Looking at 2 studies, one from Portugal and one from France, you see that the Portuguese patients had a higher rate of microalbuminuria and overt nephropathy as compared to the French study. But one thing that's different is that the mutations are different in the 2 studies. So the mutations may determine the frequency of renal involvement. And that still needs to be confirmed in larger studies. So I told you the treatment for ATTR are either gene silencers or stabilizers. Now, why is that important? Because this study looked at the kidney function in patients with ATTR treated by different types of therapy. On the left panel is the liver transplant patients, and as you can see, their GFR all dropped after that. Renal stabilizers, or the ATTR stabilizers, the renal function mostly dropped. But look at the kidney function in the RNA silencers. They tend to be stable or improved. And in fact, if you looked at patients more closely, the proteinuria also followed the same suit, whereas patients that are treated with liver transplant and silencers, the proteinuria didn't improve, but patients that were treated with RNA inhibitors did. This is several patients that actually switched therapy to an RNA silencer, and as you can see in the yellow lines, proteinuria dropped after the switch. And if you look at renal survival, the RNA silencers are represented by the red lines, and they all survive, whereas patients treated with liver transplant did not. And then finally, I'm just going to talk about this antibody. Remember that antibody targeting amyloid did not do well in patients with AL amyloidosis, but Dr. Gilmore and colleague found 3 patients where they had spontaneous remission of their ATTR, and it turns out they have a polyclonal antibody targeting the ATTR. So, in the interest of time, Dr. Nasr already talked about a lot of the ALEC2. He talked about the ethnicity that are very common in ALEC2 amyloidosis. So I'm not going to go over a lot of this. One thing is that ALEC2 is seen in other organs besides the kidney, but only the kidney is really symptomatic. We never see symptoms from the other organs that are involved. And one thing we note is that there are 3 subgroups of ATTR patients. One that maintained their kidney function quite well, and one that declines slowly and one that declines rapidly. We're currently in the middle of studying the risk factors that predict these patients. This is just a slide reminding us to look for amyloidosis in our patients. Again, multi-organ presentation, comorbidities, family history, where the family is from. Dr. Nasr went over a lot of this. First thing to do is do a monoclonal protein studies to rule out AL amyloidosis, and then mass spec if you have it available, or immunohistochemistry to type the amyloid. Dr. Nasr also went over this, so I don't have to. And with that, I will close and take questions.
Dr. Nelson Leung, for beautiful talk. Difficult, but beautiful. Now it is open for questions.
Your talk. This is a question for Dr. Nasr. I would like to know whether you consider the intracellular amyloidosis deposition a form of light chain proximal tubulopathy, and what advice would you give us to differentiate between forms besides performing electron microscopy? Thank you.
Yeah, that's a very good question. We have seen some of these cases that have fibrils within the cells, but they stain concurrent negative, and we consider them not randomly oriented. We consider them light chain proximal tubulopathy. But in this one, is distinct. First of all, they are mostly lambda. Second, most of the cases, 80%, are associated with amyloidogenic cast nephropathy. And third of all, none of them documented that they have a Fanconi syndrome or any proximal tubular, at least proximal tubular dysfunction, and the proximal tubules and distal tubules are equally affected. So I would say it's more of amyloid rather than light chain proximal tubulopathy. And then again, because they have this cast nephropathy, probably it's an early, and maybe if they don't have the cast nephropathy and you follow them for years, then they might have some proximal tubular dysfunction.
Thank you.
Hello. Well, excellent presentations. Well, I have a question for Dr. Leung, and it's specifically on ALEC2 amyloidosis. So the underlying pathogenesis is not well understood. So there's this ethnic predisposition. So I was wondering if you think this is more like a genetically driven condition, or if there is any not yet known underlying acquired factor that drives the pathogenesis. And the second question is the current treatments are more like supportive care, right? Like there are no specific treatments. So do you think like this type of new gene silencing therapies could have a role specifically targeting this production of this liver produce protein?
Excellent question. I don't think I have an answer for you for ALEC2 because, in ALEC2, despite the fact that it is it's more common in certain population, we have not found a genetic mutation. And the other thing is that it is very uncommon to find two first-degree relatives with ALEC2 amyloidosis. So genetic doesn't seem to play a role. Now, people have found that ALEC2 patients are homozygous for the G allele for the LEC2 gene. However, if you look at certain populations in Europe, in Mexico, 60 to 70% of the population have homozygosity for the LEC2 gene. So that by itself doesn't seem to explain it. And there was a recent report of a patient who was not homozygous for the G allele. You make a very good point. There's probably a second protein or gene that is causing the ALEC2 to form, or maybe that there's a decrease in the breakdown of ALEC2 causing them to accumulate. Whatever that is, we have not been able to find it yet, but certainly we are looking for these markers. Your second question about using RNA silencers and ASO, I'll tell you this when you invite me back for the next talk. There are a lot of developments. In the interest of time, I can't discuss them. But yes, we are starting to use that. And in fact, after this paper comes out with the mutant SAA1, we have a subsequent paper showing a treatment with an antisense oligonucleotide in our patient.
Thank you.
This question is for Dr. Leung. The result of daratumumab in AL amyloidosis is excellent, but sometimes in our team we wonder if in patients with very massive nephrotic syndrome, the daratumumab, that is a drug with a very high percentage bind to proteins, should be start from the beginning, or we should use other type of chemotherapy?
So that's an excellent question, and it's a problem that is recognized by Jensen. So when they did pharmacokinetics, they saw that it is the area under the curve is much lower in patients that are severely nephrotic. However, they did not make any adjustment to the dosing. And I think that's a good point, is that in the severely nephrotic patients, are we underdosing them? Unfortunately, because there's no recommendation, there's no clear direction as to where to go. And I can tell you that typically when we see a patient fail the DARA VCD, we would alter the therapy without altering the dosing of the daratumumab, partly because we don't have a good way of testing the level. Actually, we approached them with a study and they weren't interested for some reason. But I think you bring up a very good point that that some of these patients are underdosed, and Jensen actually knows, they have the data that showed that they are underdosed, but for some reason we haven't altered the dosing schedule for these patients.
Thank you.
Thank you very much for these excellent talks. I have two questions. The first question is for both of you. It's a curiosity. There are in the literature some case reports of obese patients without other comorbidities who developed secondary amyloidosis, AA amyloidosis. Do you think that this link really exists, the possibility of morbid obese patient without skin infection, etc., can develop secondary amyloidosis?
Yeah, I mean, that's an excellent point. You're referring to a study from England that they found many of these patients who don't have any risk factor for AA amyloidosis except obesity. And it could be because of this pro-inflammatory milieu in obese patients. But, you know, the problem with that is that many of the AA patients, we cannot rule out these hereditary forms unless we have a systematic genetic workup. So, I mean, I have not observed this, but it's just something hard to prove. You know, there is no solid evidence for it.
Yeah, and I have two patients, but remember that obesity is an epidemic in the United States, so it's hard to rule it out. I can tell you this, and again, if I get invited back, I can tell you the whole story. But for us to find that mutant patient, it took us over 10 years. And that's because when we did the mass spec, The mass spectrometry did not pick up the mutant peptide because it was hidden by a tryptic cleavage site. And so it was only because by chance we were doing whole genome sequencing on patients with AA amyloidosis from the previous promoter mutation study that we actually got that, we found that mutation. So had we not been lucky and just did a random, I mean, we were using them for negative control and then we found the peptide. So unless someone is doing genetic studies on all of these patients looking for mutant SAA, I don't think that, you know, it's a possibility, but you can never exclude other probable causes.
Yeah. And the second question is about the interval between the achievement of hematological remission in AL amyloidosis and the onset of renal remission. No? What is your experience or the time we could expect for?
So it depends on which cutoff you use. We did a study looking at several different response criteria, and there are actually 3 different response criteria out there. There's the Palladini response criteria, which starts at 30%. There is the old International Society of Amyloidosis response criteria, which the cutoff is 50%. And then there is the Castridis criteria, which uses a protein to EGFR ratio. It's 30% increases or decreases. If you look at 30%, you can find patients that have a renal response at 3 months, but the specificity is poor. It doesn't become more specific until 6 months, because during that time, hemodynamic changes and other things can fluctuate, and so the renal response and progression is not very good at 3 months. At 6 months, it's better for 30%, but if you choose the 50% criteria, you actually need to go to 12 months, which is what the new Mutar graded response criteria uses, 30-60. To get to that 60, you really need to wait 12 months for the patient to know if they're going to respond or not. Now, these patients don't just go along and then all of a sudden drop to 60. So you can see them going down over time. But if they're not going down by 12 months, or if they didn't go down by 30% at 6 months, their chances of getting a 50% response at 12 months is very low.
Okay, thank you.
I think it's time for coffee. Thank you very much for your participation and for your excellent talks.